Good morning, everyone. My name is Camilo Gonzalez Velasquez, co-host of the Thyroid by MD's webinar series. I want to thank you all for being here with us and hope you're having a great start of the year. Today, we're honored to have a couple of young researchers and rising stars in thyroidology. First, I'll introduce Dr. David Toro Tobon, a distinguished third-year clinical and research endocrinology fellow, and he's assistant professor of medicine, Mayo Clinic, Rochester. Dr. Toro Tobon is a graduate of CES University in Colombia in Medellin and resident of Georgetown University Hospital. He's a specialist in clinical thyroidology with a keen interest in integrating artificial intelligence into thyroid disease assessment and treatment. His groundbreaking research spans natural language processing for thyroid cancer data, innovative therapies for thyroid eye disease, and redifferentiation therapy for metastatic thyroid cancer. He's a very active member of the Mayo community. Dr. Toro Tobon has numerous publications, presentations, and significant roles in medical education and training. We're also pleased to welcome back Dr. Max Schumm. He's currently concluding his chief residency in general surgery in UCLA. Dr. Schumm is an alumnus of the Medical College of Wisconsin, and his research during 2 years in the UCLA and endocrine surgery program have significantly advanced the understanding of surgical outcomes, molecular testing, and the optimization of treatment of well-differentiated thyroid cancer and adrenal nodules alongside with surgical education. Dr. Schumm is preparing to further his expertise with a fellowship in endocrine surgery in NYU this upcoming 2024-2025 academic year. Today, Dr. Toro Tobon will present his recent publication on variable aggressiveness in treating differentiated thyroid cancer and its correlation with physicians' attitudes and local practice environments. This is set up to be a fantastic presentation. Before we begin, I'd like to encourage all of you to send any questions through the Q&A function, and we'll try to get to as many of them as we can by the end of the hour. So now I'm going to hand off the control to David. The floor is yours.
Good morning, everyone, and thank you so much, Dr. Gonzalez, for your introduction. Happy to be here. I hope we can discuss a little bit of this within the next hour and hopefully have a very nice conversation by the end. As Camilo was saying, we're going to be talking about treatment aggressiveness for differentiated thyroid cancers and its variations and influence by physicians' attitude and local practice environment. There's no conflicts of interest or financial disclosures related to this presentation. And truly, most of what we're going to be discussing here is from Dr. Schumm's research and his team. This paper on perception of risk and treatment decisions in management of differentiated thyroid cancer was published in August 2022. It comes from his group at UCLA. There's a mix of endocrine surgeons, internal medicine, endocrinology, and surgery. Hopefully I'll be able to guide you through background, methods, and results. And then with Dr. Schumm, we'll have some discussion about what to make of these results. Now, the first thing is why is this important? So this takes us to the background. Before 2015, there was this conception of one size fits all. That was how cancer, differentiated thyroid cancer at least, was approached. So once the diagnosis was established, most patients would go through near total thyroidectomy. They would receive radioactive iodine, and they would end up with T4 suppression therapy. Now, even though this was universal, in 2015, the question became, does one size really fit all? And this is because of a couple of factors. First, being overall differentiated thyroid cancers have really good prognosis, most patients, especially those with micro PTCs that had complete resection, no nodal disease, no extrathyroidal involvement. Disease-specific mortality is very low, it's 10%, and this can go from 0 to 100% depending on the specific histologies, phenotypes, genotypes. And a progression-free survival at 5 and 10 years is also very small, 90 or very good, I would say, 96% at 5 years, 94% at 10 years. Again, depending on genotype, phenotypes, this can be a little bit higher, a little bit lower. But in general, really good prognosis. And within the differentiated thyroid cancer categories, there's variations in the clinical, molecular, and pathologic profiles. There's also increased morbidity and from cancer therapy and adverse effects from cancer therapy. So With all these kind of improvement in characterization of the disease and better diagnostic techniques, better surgical techniques, what the 2015 guidelines from the American Thyroid Associations did was switch the paradigm towards risk-based strategies to manage these patients. And as you can see on the screen, it was divided between low risk, high risk, and intermediate risk categories. This is intended to be a continuum of risk. It's not like the categories have a really hard stop in between them. And this is going to be important because this might explain, as we're going to see in a couple of slides, some of the variations in practice between physicians and providers in general. So after this 2015 iteration of the guidelines and the switch to risk-based strategies, when we have a patient with differentiated thyroid cancer, now we have kind of different pathways. We can have patients with low risk, in which case we can do surveillance if we're talking about micro-PTCs. We can do lobectomy or near total thyroidectomy. If we have a patient with high risk, then we go towards the traditional route, near total thyroidectomy, radioactive iodine, T4 suppression therapy. And here's where the big problem comes into play, intermediate risk. When we have this one, we're gonna split a little bit the patients. If there's no risk modifiers, we're probably gonna treat them more closely to what a low risk entails. If they have risk modifiers, they're gonna be treated a little bit more similar to the high risk. But again, keep in mind that there's not really hard cuts in this continuum of risk. So there might be variations in the way physicians interpret a patient as being intermediate to low risk versus intermediate to high risk. So there's not a really hard cut in those categories. Now, these guidelines, there's been several publications trying to see whether they are accepted or not, and what can affect their implementation. But in particular, this cross-sectional survey was conducted in 2020. This was from the group of Dr. Soka. And what they did is they surveyed the ATA membership. They get a 19.8% response, which is around 348 respondents. And what they found out is that 92.9% agreed with the statements from the ATA guidelines from 2015. Around 83% regularly use the guidelines in their practice, or at least reported regularly using the guidelines in their practice. And around 83% agree that the recommendations were easy to incorporate into practice. So these numbers look very good overall, right? But again, this is self-reported. This is not based on specific cases. It's just kind of the respondents per session. There have been some guidelines disagreements, and for those of you who might have not read it before, there's a very nice editorial kind of commentary from Dr. Daniels and Dr. Kopp in 2019. This was in response to some critiques that were made to the 2015 guidelines after they were published. And what they explained pretty much is what are the reasons behind the disagreements with the guidelines. And there's three big categories, one of them being regional differences. There's just a difference in the prevalence of disease in different parts of the world, United States versus Europe versus Asia. There's also differences in resources, availability, in expertise of the surgeons. So these can actually impact the way we interpret the recommendations and the way we apply those recommendations. There's also difference depending on who's the primary specialty taking care of the patients. The approaches might be different if they are being primarily guided by a clinical endocrinologist versus a nuclear medicine specialist versus a surgeon. And finally, there's really lack of high quality evidence for a lot of these recommendations. So one could argue that there's going to be disagreement just inherent to that. And finally, we have a last factor affecting these decision-making, and there's a constellation of different components, including patients' preference and psychosocial perspectives, patients' age and comorbidities. just physicians' experience, attitudes, perception of risk versus benefits. The surgeon's training, it's different if it's a surgeon that has been through endocrine surgery fellowship versus no fellowship, local practice patterns, resource availability, and burden of care. So pretty much, as you can see, we are coming back to what's happening right now, and is that we have a patient with DTC, we try to go by the guidelines. If we have a patient with high risk, it's pretty straightforward, and I think most of the providers will agree on going towards the regular path, near total thyroidectomy, radioactive iodine, T4 suppression therapy. But the problem comes when we're facing patients with low to intermediate risk, because there's a lot of factors involved, including guidelines disagreement, new evidence, and just other factors affecting decision-making. And these patients end up having a diversity of kind of pathways. The approaches tend to have a lot of differences in between providers, especially in the low to intermediate risk. So this is as part of the motivation why Dr. Schumm and his team decided to really assess what's the perception of risk of disease progression and recurrence, and what's the impact on treatment aggressiveness. It's especially in patients that have low to intermediate risk differentiated thyroid cancer. And how did they do that? So this was cross-sectional, it was survey-based, and as opposed to the previous assessments of guidelines and kind of like what perception of the guidelines was, here the team wanted to put things into perspective. So it was more based on cases. The survey was distributed to all the ATA membership. Around 183 patients responded, participants responded, and this is approximately 13% response rate. It was composed of clinical endocrinologists, endocrine surgeons, medical oncologists, nuclear medicine physicians, and it pretty much mimics or reflects the representation within the ATA membership. This protocol was approved and reviewed by the IRB board at the UCLA, and informed consent was required. So as I was saying, every participant was faced with 4 scenarios. All of these scenarios were low to intermediate risk. There were no significant comorbidities or surgical factors, and the reasoning behind it was to eliminate other factors that could affect decision-making. So they wanted to make the cases as straightforward as possible. The first case was pretty much a patient with an indeterminate thyroid nodule that had a BRAF mutation. The second case was a Tolso variant PTC that was biopsy proven and had undergone lobectomy. The third case was a papillary thyroid microcarcinoma. And the fourth case was a classic papillary thyroid carcinoma, intrathyroidal, 2 centimeters, completely resected, or no other lesions, I would say. And the participants were provided with 2 treatment choices. These treatment choices were deemed to be less aggressive or more aggressive, and they range from just observation and active surveillance to completion thyroidectomy, assuming that after near total or completion thyroidectomy, you would go for radioactive iodine as well. In addition, participants were asked their perceived risk of permanent complications after thyroid resection, structural cancer recurrence at 10 years following thyroid lobectomy, structural cancer recurrence at 10 years following thyroidectomy and radioactive iodine, and progression of a papillary thyroid microcarcinoma at 5 years with active surveillance. The analysis was pretty much based on descriptive statistics. There was weight and non-weight logistic regression with binary scales. They tried to make things very simple for the reader, kind of dichotomizing it between more aggressive and less aggressive. They also measured the absolute difference in the probability of recommending more aggressive versus less aggressive treatments. And they did this by using physicians that perceived the risk-benefit to be 1 standard deviation below the average and 1 standard deviation above the average. And finally, they evaluated the proportion of the variation in treatment decision that was explained by the differences in the assessed risk and benefits. All of this was done kind of on a scale of 1 to 100. Now, results, responding characteristics, as I mentioned, it was 183 participants, a response rate of 13.4%. 64% were male, 63% of these respondents were in academic setting, 49% were adult endocrinologists, and 26% were endocrine surgeons. And the median of practice that is related to thyroid disease or dedicated to thyroid disease was 60%. Compared to the local practice patterns, the participants considered themselves aggressive in 9% of the cases, moderate 61%, and conservative 30%. And importantly, 86% considered that their practice was aligned with their local practice patterns. So this is what happened specifically with the cases. The recommended treatment for the 4 cases that were proposed, as you can see, none of them had a single agreement of more than 70% on any treatment. So this is important because even though we go back and we saw that 92% agreed with the guidelines, 83% applied the guidelines, 83% thought it was easy to apply, we're seeing here that not a single intervention was applied in more than 70% of the cases. So for the indeterminate nodule with BRAF mutation, we have that most participants went for thyroid lobectomy, completion thyroidectomy, if needed. Then the minority 30% went for total thyroidectomy. In the patient with torsal variant PTC after lobectomy, it was pretty much split between observation and a large proportion that said thyroid lobectomy, completion thyroidectomy. In the case of the micropapillary thyroid cancer, we have a little bit of everything. We have 36% that went for observation. Thyroid lobectomy was considered in around 60%, and the rest was total thyroidectomy. And finally, the classic PTC without extrathyroidal extension, no lymph nodes, just a single lesion. Most patients, participants went for thyroid lobectomy, but there was still a large percentage, 35%, that went for total thyroidectomy. So as you can see, there's really wide variation in the treatment strategies that were implemented. The perception of operative risk, we have lobectomy. There were evaluated 2 risks here after surgery. We have recurrent laryngeal nerve injury and hypoparathyroidism. In terms of the laryngeal nerve injury, lobectomy and near total thyroidectomy were associated with 0.5 and 1% risk, and hypoparathyroidism was associated with 2% risk. In general, I would say surgeons appear to have a slightly lower perception of the risk of recurrent laryngeal nerve injury with lobectomy and near total thyroidectomy, meaning medical endocrinologists were a little bit more concerned. These are the 4 cases, and we're not going to go in detail through all of those. But what I want you to see is that there's really large fluctuation in the responses for these cases. What we're seeing in the first 2 columns is the perception of risk recurrence. The first one is with less aggressive treatment. The second one is with more aggressive treatment. And the third column is just showing us the perceived risk and what's kind of like the risk reduction by implementing more aggressive versus less aggressive treatment. Again, I'm not going to go through all the specific numbers, but what I want you to see is, for example, in this case 2, the torsal variant PTC, you can see that the cancer recurrence risk with less aggressive treatment was pretty much something from 0 to almost 100%. And for the more aggressive treatment, which was completion thyroidectomy, is also up to 60-70%. So there's a really wide range of responses. Even though there was, of course, predominance of like 0 to 10, 0 to 20%, there's still people that consider 80 to 100% risk. So really wide variations here. And the perceived or the absolute risk reduction for the case with indeterminate nodule was 2.7. For that with also variant PTC was 9.2. Case 3 and 4, we also see a lot of variation, as you can see, 0 to 80%, 0 to 60%, 0 to 70%. So a lot of different estimates of risk, regardless of the conduct. And the absolute risk reduction was 12.8 for the case of the micro PTC, 4.4 for the case of unifocal PTC. So what was the influence of risk perception on decision making? And what Dr. Schumm and his team estimated is that the differences in cancer recurrence risk reduction only explain 10.3% of the variations in treatment options. So even though the guidelines are designed to be risk-based and the strategies are supposed to be risk-based, our estimation of the risk is only explaining 10.3% of those variations in treatment options. Physicians with greatest perception of absolute risk reduction on recurrence with more aggressive therapy, meaning those above the mean, one standard deviation, were 15.1% more likely to choose more aggressive treatment. However, this effect was not equally seen across all vignettes. Not all the cases were consistent with this result. And interestingly, the operative risk really didn't have an association with treatment choice. Now, the self-perceived risk attitude compared to the local practice environment was associated with more aggressive treatment in two scenarios. First one was the indeterminate nodule with BRAF mutation. In this case, we have an odds ratio of 4.5, and it was statistically significant. And the other case was the 2 centimeter classic PTC, which case the OR is 9.7 and statistical significance based on the confidence interval. In these two scenarios, the perceived risk reduction was not really associated with the treatment recommendation. Finally, the advanced career physicians were more likely to recommend more aggressive treatment in two scenarios. The first one was indeterminate nodule with BRAF mutation. In this case, we have an OR of 3.57. And the second scenario was the 2 centimeter classic PTC with an OR of 3. And this is comparing advanced providers more than 20 years compared to mid-career 7 to 19 years of practice or training. So in summary, what Dr. Schumm and his team showed in this article is that there's a wide variation in physicians' perception of the risk of disease recurrence and treatment choices for patients with low to intermediate risk, DTC. Physicians' risk was estimated largely, or the estimates do not really explain the variations in treatment aggressiveness. In self-identified risk attitude, local practice environment, and greater number of years in practice were significantly associated with higher likelihood to recommend a more aggressive treatment approach. And with that, I will thank you all. I will pass the microphone to Dr. Schumm, and happy to participate in the discussion at the end.
Great. Well, thank you so much for that amazing review. And good morning, and thank you everyone for coming and listening today. I'd like to thank the Thyroid Journal Club for having me. My name is Max Schumm, and I'm a chief resident in general surgery. And I'll be starting my endocrine surgery fellowship next year at NYU, and I'll be doing a discussion in decision making in endocrine surgery this morning. I have no disclosures. In surgery, the decision of when to and when not to operate is thought to define a great surgeon. Whatever benefit an operation or treatment may bring will have to exceed the potential for harm before the doctor is considered to be doing good. Unfortunately, many treatments may have no benefit or only marginal benefit, and most with inherent risks. So how do we make the decision to operate? According to normal decision theory, a fully rational, ideal decision maker identifies the optimal decision by weighing the likelihood and attractiveness of the options. This initial decision-making study is led by a co-resident and myself and Dr. Wu, who's the senior author on our paper, and the findings were quite interesting to us. Let us want to examine a similar topic, but in endocrine surgery. In this study of a national sample of nearly 800 surgeons, 4 clinical opinions were presented, with the surgeons asked to estimate the risks and benefits of operative and non-operative management, and then to report how likely they were to recommend an operation. I want to give an example of one of their vignettes, which included a 19-year-old female with 3 days of pain in the right lower quadrant. She was febrile and tachycardic. She had a soft abdomen but had tenderness focally in the right lower quadrant. And on CT scan, there was a large phlegmon with stranding in the right lower quadrant, some free fluid in the pelvis, and the appendix was not seen. The surgeons in the study were then asked to decide between surgery versus observation, which are both considered acceptable treatments for this pathology. In this case of a complicated appendicitis, surgeons in the study perceived very wide variation in operative risk. When these national cohort of surgeons' risk perceptions are compared to recent meta-analysis data, operative risk and complicated appendicitis in the red
Max,
box.
I'm really sorry to interrupt. I truly apologize for doing so. I think there's something going on with your microphone, because we're hearing you a little. You're breaking up a little.
Is it better?
I think so.
Okay, sorry about that. Let's continue. In this meta-analysis data, just when this meta-analysis data is compared to the risk perceptions of the surgeons in the study, we'd see that there's actually a higher operative risk, which is seen in the red, than perceived by the study respondents. Again, when this meta-analysis data is looked at and compared to the national sample of risk perceptions of non-operative risks, again, there's a difference, and we see that the meta-analysis data would suggest that there's a lower non-operative risk, again, seen in the red, than perceived by the study respondents. And finally, when the surgeons were asked how likely they were to recommend a laparoscopic appendectomy in this case, we can see that the respondents were really all over the map with their recommendations. When all 4 risk-benefit judgments were included into a regression model, there remained a significant association between all 4 judgments of risk and benefit and the decision to recommend an operation. If we look at the operative risk, we can see that surgeons were significantly less likely to recommend an operation as their judgment of the risks of operating increased, and more likely to recommend operation as their judgment of benefit of operating increased, which makes sense. When we average all vignettes and look at the mean operative risk, all 4 cases, the mean operative risk was going to be 39%. And using similar methodology, when they look at the risk perception of those with 1 standard deviation below the mean, these surgeons had a 78% predicted probability of recommending an operation, while surgeons judging the operative risk at 1 standard deviation above the mean would have a 48% predicted probability of recommending an operation. Although this was a 30% difference, it's not as great as what others would have imagined, considering the extremes of these risk perceptions. These potential flaws in decision-making can be explained by several cognitive biases that are described in behavioral science. These include things such as the availability bias, which is a mental shortcut that relies on immediate examples that come to mind to a given person's mind when evaluating a specific topic. The overconfidence bias, which is a bias in which a person's subjective confidence in their judgments is reliably greater than the objective accuracy of those judgments, especially when their confidence is high. The bandwagon effect, which is a bias in which the tendency for people is to adopt certain behaviors, styles, or attitudes simply because others are doing so. And the commission bias, which results from an obligation towards emphasis and is a tendency towards action rather than inaction. I've discussed this paper many times on its implications in endocrine surgery. We decided to embark on a project in similar methodology. I serve as a thyroid specialist in the ATA. I'm not going to go too much into the results again because they were excellently presented, but I want to focus on one case, which is the case 2 of Paul variant PTC. which show the highest variance and explain differences based on perception of operative benefit, which will be classified as reduction in cancer recurrence risk. In this case, 42% of our respondents recommended observation, while 58% recommended completion of thyroidectomy. And I will dive a little bit deeper into in these charts, but we can see here that after the less aggressive treatment, it was just a thyroid lobectomy, estimated risk of structural cancer recurrence after 10 years was a median of 15%. When the respondents judged the risk of cancer recurrence with more aggressive treatment, which was a lobectomy, which was a completion thyroidectomy with iodine and ablation, estimated risk was in 10 years recurrence was decreased to 8%.
Max, I apologize again. You're breaking up a bit. I don't know if it's only on my side. David, can you hear him? Are you having trouble with the audio?
It's breaking intermittently. I wonder if it's internet connection.
Okay, third time's a charm. Focusing in on the perceived operative benefits, which again is the risk reduction with the more aggressive treatment and with the less aggressive treatment. We found that even when these thyroid specialists in our study had risk estimates that were 1 standard deviation below the mean, which implies very little benefit in performing the more aggressive therapy, which was the completion, because these risks would be about the same, they still recommended the aggressive therapy over 40% of the time. And then when we looked at respondents with risk estimates 1 standard deviation above the mean, which implies the greatest benefit of performing the completion, the recommendation for aggressive therapy was seen in 74%. Indeed, this is a difference, but one we hypothesized that would be much larger in a situation like this. The most interesting findings from this study described in a real-world scenario is that when patients go to our office and ask what the risks and benefits of surgery are, the percentages that we quote may not tell the patients how we are going to behave and what we recommend. Instead, the way that we see ourselves, for example, as conservative or aggressive, and what our local practice patterns and practice settings are, may carry much more weight. We feel that there are some next steps that may improve decision-making in endocrine surgery. These include the use of such things as risk calculators, decision aids, and improvements in shared decision-making. Dr. Sachs investigated the impact of a surgical risk calculator in a randomized trial format as a secondary analysis of his prior study. Surgeons were randomized to either receive the risk calculator's values prior to making their risk estimates and treatments, and those that did not get exposed. And what he found was that surgeons exposed to the risk calculator judged levels of operative risk that more closely approximated the risk calculator value compared with surgeons in the control group. And additionally, surgeons exposed to the risk calculator also varied less in their assessment of the operative risk. Here we can see that the gray boxes are those that were not exposed to the risk calculator, and the boxes outlined with the black line are those exposed to the risk calculator. The red line depicts what the risk was as predicted by the risk calculator. Although the predicted risks, when supplemented by data from the risk calculator in the study, were more in line with those quoted in the literature, interestingly, it did not change the surgeon's behavior. The likelihood of them recommending an operation was similar, seen in the red box. There's a similar phenomenon seen in the use of antibiotic prophylaxis in thyroid and parathyroid surgery, which shows that there are no benefits in reducing surgical site infections when antibiotics are given. And this data has been demonstrated across RCTs as well as meta-analyses, and was more recently published as a strong recommendation in the AAES guidelines just a few years ago. However, in survey studies of antibiotic use varies widely, and over 25% of endocrine surgeons report almost always using them. Data does not equal behavior. We think that decision aids and shared decision-making may also play an important role in endocrine surgery. Re-examining the case of our papillary thyroid microcarcinoma, recommendations varied across active surveillance, lobectomy, and total thyroidectomy. However, in recent studies, over 70% of patients with papillary thyroid microcarcinoma choose active surveillance over surgery after receiving counseling about their treatment options. In this decision-making study, patients were provided with standardized medical information and were interviewed after making their decision, which dictated their disease management. 71% of the participants chose active surveillance. 94% were independently able to make their own disease management choice, and the rest shared the decision with their physician. And there was a 98% decision satisfaction reported. On the contrary, when physicians were surveyed on barriers to the use of active surveillance, 80% reported that patients did not want this modality of treatment, and nearly 60% reported patient worry as a primary concern. Physicians can often fail to consider patients' key decision factors and misjudge what patients with thyroid cancer value. These results are contrary to the results that we found in our study, and in this discrete choice environment, patients would accept a modest increase in the risk of cancer recurrence to reduce the risk of hypocalcemia or recurrent laryngeal nerve injury. We decided to explore the influence of patient preference on treatment decisions in a secondary analysis of our data, which was recently published in August. We used the same clinical vignettes and survey respondents and found that over 90% of respondents would offer the alternate therapy after their initial treatment recommendation if the patient requested it. In this figure, we can see the risk perceptions of our study respondents, and we found that physicians who declined the request for less aggressive or more aggressive treatment did not perceive a different risk of cancer recurrence or permanent surgical complications than physicians who complied with patient requests. And overwhelmingly, the vast majority, like I said, 90%, complied with patient request. Additionally, respondents were willing to comply with patient preference, even if it increased the perceived risk of permanent surgical complications or cancer recurrence up to 20%. These are patients that were well informed and voiced their understanding. In summary, variations in treatment recommendations are largely not explained by differences in risk perception. Most physicians are willing to listen to patient preference, and the key may be to get patients to a point to consider their choices and voice their preferences. Patients may choose different treatments for their thyroid cancer if given the opportunity to become well informed. And finally, even when a patient may tell you that they want you to choose, physicians should have the awareness to ask them what matters to them and do their best to elicit their preferences and values. Thank you all for your attention.
Thank you both for very interesting presentations. I want to congratulate Max for your group's work. I think this brings more questions than answers currently, and it resonates a lot with a discussion I had way back in the day when the pandemic was just beginning. I sat down with Dr. Mark Erkin, and I realized my worry of how it is difficult to sometimes implement guidelines as they are in the clinical practice. And this was kind of like the foundation of Thyroid. I am worried, or not worried, I should not say worried, but I am surprised by the number of respondents from the ATA membership in the surveys. And I am also surprised by how they respond and how they act. When we say the ATA membership, we kind of feel like we're preaching to the choir. And it should have kind of a uniform posture on how to react to certain treatment, and more so to data that we have from the literature. So what are your thoughts, Max, on why this happens? Why do we say we follow guidelines and then not? Is it worry? Is it education? Do we need to educate the whomever's treating it? And let's always remember that we are surveying people that are mostly in academic centers and not thyroid cancer care in the community as mostly it happens?
Yeah, that's a good question. I think it's multifactorial. I think in endocrine surgery, the over 50% of surgeons that perform thyroid or parathyroid surgery do so just a few times a year. And everyone may not know of the guidelines or be in tune with them. I think there's also a fear of bad outcomes, and not wanting to have any big misses and leading us to kind of be more aggressive at times. And I also think that your local practice environment and the views of the people referring patients to you can play a big role as well, and wanting to, not have bad interactions or create enemies with colleagues that are where there's a mutual kind of relationship and respect.
Right. When we speak, you hit the nail right in the head. You were saying that most thyroid surgeons or people that perform thyroid surgeries perform only a handful of them in a year, and there's this very well-known concept of the high versus low volume surgeon, and we keep on going back to that concept. And when I was listening to the data, we often read and see physicians who have more years practicing tend to behave this way. They tend to be a little bit more aggressive. There's a few papers that mention the endocrinologist volume or the clinician's volume in treating thyroid cancer and how they also behave a bit different. But we've never heard, or I haven't heard at least, I don't know, David, what are your thoughts? Do you think that physicians trained prior and after the 2015 iteration of the guidelines would tend to have different behaviors or aggressiveness while treating thyroid cancer?
Yeah, I think there is some data to show that it takes a few years, there's some lag time, and I think that that probably is data that reflects everyone, and maybe more so people that are more used to their ways. I think a similar analogy can be like thinking about laparoscopic or a robotic surgeon, and there's still some surgeons that are older that maybe have not even adopted those practices at this point because we're used to our ways. And I hope that over time, and maybe we're seeing that more now as the guidelines are now almost 10 years old, that it's becoming more of just kind of a common practice, and maybe we'll see even increased rates. But I know that there's some recent data that still shows that over 70% of low-risk thyroid cancer is being treated with total thyroidectomy. So I think there's still a lot of improvement there to be made.
I would say I think there's definitely a difference in regards to when you train and the actual 2015 guidelines. I think there's different components that are associated with kind of the adoption of the guidelines, and it's difficult because as many of you might know, a lot of the recommendations are based on strong. It's a strong recommendation based on low quality data, and that gives a lot of room for interpretation. So if you have a physician that has been doing things a certain way for 10 plus years, and you're telling them the recommendation is this one, but we don't have pristine randomized controlled trials to prove this, it becomes complicated. And I think changing that practice is challenging. And of course, if you have trainees that are under these more aggressive or less aggressive physicians, that practice is going to be inherited a little bit. Just anecdotally, I would say it also depends on what type of disease you're exposed to. And working at a place where we have a very large group of thyroidologists and kind of subdivisions between high-risk thyroid cancer and low-risk thyroid cancer, just anecdotally, one can see how those providers that are normally working 90+% of the time with low to intermediate risk tend to be much more aggressive with those that have very subtle risk modifiers. So they're still intermediate risk, but they're looking a little bit more like higher risk, and they tend to be much more aggressive. Versus those that are usually working with high risk thyroid cancer, that their practice is 50-60% high risk, in which case when they have an intermediate risk, they tend to approach it much more commonly as if it was a low risk thyroid cancer. So I think that volume and that kind of exposure that you have in your own practice also impacts how you decide. I think the guidelines that are upcoming have a lot of challenges, mostly because, again, we're going from these one-size-fits-all to risk modifiers, but now we're introducing a lot of different aspects that we did not have in 2015. Now we have the subdivisions by phenotype, genotype from the WHO classification. We have much more data on adverse effects and morbidity from treatments. So I think the new guidelines are probably going to be filled with many more intricacies. And I think it's going to be a challenge in terms of how to disseminate the guidelines, how to write them in a way that makes sense, but that also accounts for the attitudes, for the behaviors, for the feelings, really, of the providers that are going to be using them.
This is very interesting how you mentioned the setting, the volume of a certain type of phenotype, genotype of a thyroid cancer that you're presented to and how you will react to it. That's very interesting. And I wonder how if this data, if replicated outside of the boundaries of the US, would be still be behaving in a similar fashion. What are your thoughts? From my belief, there's many things that we need to do. Max was presenting to us the decision-making tools and calculators that we could use moving forward. And to refine those, we need data and to properly analyze data. What do you think about, David, the implementation of AI to refine, to split the hairs in that intermediate group that you were mentioning is harder to make choices?
I think it's going to be really useful, to be honest, because the beauty of AI is that it allows us to analyze more intricate and complex patterns. So we're going to be able to go from saying this patient meets these criteria, yes or no, these criteria, yes or no, and because of these, you go to intermediate to this patient meets a little bit of this criteria and a little bit of that criteria and a little bit of these other criteria. And because of that, then the risk is more towards the intermediate to high versus intermediate to low. So I think it will allow us to break the bucket a little bit more, especially the intermediate risk, and probably help us make a much more personalized risk assessment of the specific patient, taking into account many more variables. Again, the beauty of these AI algorithms is that, for example, let's say thyroglobulin levels. If you are thinking about a level, it's not going to be higher than versus lower than. It's going to account for the individual level, regardless of specific individual level. Or same thing with the nodules. It's not going to say more than 5, less than 5. It's going to say 6 is going to actually be different than 4. It's going to be actually different than 5. So I think it's going to allow us to give much more personalized risk assessments.
That is very interesting. And right now, being that we're standing in an inflection point, we all know that the next iteration of the ATA guidelines is just about to be published. Max, what are your thoughts? Same vignettes once again. What have you thought about it? Doing a prospective study. What are your thoughts?
Time's a little crunch right now, but maybe next year. No, I think it's a really interesting topic to continue to explore, and I think especially when you start to do these projects, you learn a lot from each one, and you learn what you can do better. And there's a lot of things that we could have done better, and it would be interesting to do something similar, but maybe give it some time for the guidelines to kind of percolate. and investigate the new topics that are emerging from these guidelines, which seem to always occur.
Interesting to maybe include non-ATA participants. What it always catches my attention, because I think I was, as Camilo said initially, very surprised to see this degree of variation with people that are supposed to be the thyroid experts. And truth is, there's a lot of general endocrinologists that also treat patients with thyroid cancer, but they are not going to the ATA meetings. They are not having access to the regular ATA communications. So I'm just thinking, if we do this outside of the ATA, the variations are probably going to be much, much, much larger. And there's a really large group of this is prevalent enough that general endocrinologists manage actively a lot of patients with low to intermediate risk thyroid cancer.
Yes, I think that is a very, very valid point, and I think one that we must tackle. The ATA, of course, it's intended for the American population, that including North America, Mexico, maybe Canada, but there's many more countries that read and follow, or at least tend to follow the guidelines or the recommendations that come from these guidelines. So that would be a really interesting study, and that could be replicated outside of that boundary or that scenario. Having said that, I want to make a little advertisement, and it's not an advertisement. I'm going to use this time to say this is why Thyroid was born. The inability of physicians to make a decision at the bedside in a consult, that is what worried us the most. We know that people not only not being able to implement the guidelines, but to access them. That is what Thyroid. And when I say Thyroid, I'm not speaking about the Friday morning webinar series that we're currently in, but I'm speaking more for the platform where we amalgamated, we brought together recommendations from different guidelines, and we realized just what you're saying. We're just echoing what we've heard in the past 30 minutes or so. We saw that there's recommendations that are discordant. We saw recommendations that are based on low evidence. We saw that there are many ways to skin a cat, and we might not have all the answers right together. And you guys just are highlighting some of the tools that we can use moving forward. And this inflection point that I mentioned, having the new iteration of guidelines just about to come, are just a perfect moment to collaborate, to share that worry that we have, that itch that we have to know more, to treat better, to treat less sometimes, and of course to know what other physicians are doing. And I think that stepping outside of the ivory tower, as I call it, the ivory tower treatment, that very high advanced academic center, what is happening outside, because it is not only something that we need to do, but something that we have to do, is to permeate those treatment options to have better outcomes. And something we didn't speak about is quality of life and costs, and sometimes treating more definitely impacts both of those aspects of any patient's journey in a way. So having said that, I want to thank you both for being here. I want to congratulate you on your work. I certainly hope that we can touch base with you and invite you to be here once again. And I want to invite everybody to be here for next week's session. Hope everybody stays safe, stay warm, be happy, and Happy New Year.
Take care. Thank you.
Thanks.